All right, folks, so we're going to start talking about Chapter 4 today. It's going to be exciting. This chapter is psychopharmacology. Okay, so that's going to be a lot of fun. This is really going to tie into some of the stuff from Chapter 2. It's still going to be some more sort of subcellular kind of things, right? We're going to be talking about receptors and neurotransmitters and ion channels, and it's really going to be thrilling, so great job. We're going to talk again about basics of psychopharmacology, sites of drug action, and neurotransmitters. Briefly, we'll talk about neuromodulators as well, but not as much. All right. So for our purposes, we want to think about what is a drug, right? And a drug in our case, well, definition we're going to use, is anything that's an exogenous chemical, okay? And by exogenous, we mean from outside your body, right? We're going to talk about endogenous things as well. These are going to be substances created by your body. We don't typically think of those as drugs, right? Because they're not that external chemical that we're going to be using. Okay, so it's going to be an internal thing if it's endogenous. For exogenous, we're going to talk about drugs. A drug is going to be anything that alters the function of cells. Typically, this is going to be limited to a certain class of cells. For our purposes, we're really focused on what kind of cells? Liver cells. No, neurons, right? We're really going to be thinking about neurons and those cells. Okay. We're not really too concerned about the effects on other cells within your body. But there are drugs that you take that affect those, right? How many of you know someone who's on cholesterol medication? How many of you know someone who's on diabetic medication? Yeah, I mean, none of that is really affecting brain cells, right, directly. Okay, it's affecting other cells, though. Liver cells, you know, maybe you're on some kind of cardiovascular medication. Okay, maybe you're on, medications for osteoporosis, for example, right? So there are other kinds of drugs that do other things. We're going to be thinking about drugs that affect brain activity. Here's a really complicated definition. So everybody's going to have to write this. Ray, are you ready for this? This is going to be the most complicated definition I've ever given you. Drug effects. These are the changes produced in an animal's physiological process or its behavior. That's it. Right? What does the drug do to you? Right, Jasmine? If you take a drug, what is that effect? Okay. What is that behavior? What is that physiological process that's going to be altered? Okay. The other thing we want to think about is the site of action. And this is just where molecules of that drug interact with molecules that are in or on the cells of your body, okay? This is actually where we can make changes and affect that biochemical process. It's going to be that interface between the substance that you take and your body. To really understand what a drug can do, how long it can do that, and how well it can do that, Emily, we really need to think about what's called pharmacokinetics. Okay? And for pharmacokinetics, we want to think about 4 processes. We want to think about the way that drugs are absorbed, the way they're distributed, the way they're metabolized, and the way that they're excreted from your body. Okay? You don't have to raise your hand, but I think everybody could raise their hand safely for this. How many of you have ever taken a drug? Yeah, like Advil, right? I mean, how many of you, or ibuprofen, right? So I'm not like throwing out a brand name there, right? You can use off-brand ibuprofen if you want, Jason. It's totally up to you. I guess it'll work the same. Don't take medical advice from me, but it'll work the same. So you've all taken probably a pain medication, right? You've taken a Tylenol, acetaminophen, something like that. Not too big of a deal. That's still not working in your body, is it? I mean, unless you just took it before you came to class. I'm going to assume it's not working anymore. The Advil you took last week because your knee was hurting is not still preventing your knee from hurting today, is it, Abby? No, you have to take it again because that gets excreted, right? How many of you, here's a real personal question. Here we go, Regan. How many of you have ever had funny colored urine? Yeah, right? Probably the same ones of you who've taken a drug, right? Your urine gets a funny color. Anybody take a multivitamin? Yeah, and you notice, like the next time you urinate, why is it blue? No, we got some good multivitamins. Actually, that would probably be a bad multivitamin. We'll talk about why in just a moment, because it's not staying in you. But quite often your urine will turn a little different color, right? Sometimes it gets kind of bright and neon colored. Anybody had that one? That's pretty common. Yeah. If it's red, that's a problem, and go to the doctor. Just as a heads up, don't think like, wow, I took that multivitamin, I've got red urine now. That's a health concern. You should get that checked out. Especially if you screamed the entire time you were urinating. And it was red. So there you go. You can call your parents and tell them all the great medical advice you got today. Hey Mom, if your urine's ever red, call the doctor. In case you didn't know. Some people don't know. It's just important. All right, so we're going to think about those 4 processes, right? I love this particular image because it makes you all think you need to see the eye doctor. It's actually very fuzzy. Yeah, some of you are thinking like, oh, my prescription is not working anymore. And Eloise is thinking like, how am I going to make it through batting practice today? Because I'm not going to be able to see the ball. So, here are the 4 components. Absorption. This is how the drug gets from the outside world into your body, right? And there are a lot of ways for absorption of drugs. We'll talk about those. Most of you have experienced more than one method of drug absorption, okay? I'm going to make that as a pretty good statement because I know most of you have taken oral medications. I think probably everybody has, right? You've all taken some Advil, some Sudafed. You've taken, your Flintstone vitamins, right? Eric's like, yeah, I still take my Flintstone vitamins. I feel bad because they make like adult chewable vitamins, and I'm thinking like, I mean, if you need adult chewable vitamins as like your average everyday person, there's a problem. Just swallow the regular.
Are they not as good? Or
I just feel like I don't.
There's an age limit.
Huh? There's an age.
There's an age limit.
I think so, right? I think when you get a few decades and you're still eating chewable vitamins.
You pay taxes, you should chew your vitamins.
Yeah, I think I like that. I like that actually. So there you go. Keep that in mind. And it is tax season, so that was a great plug. Keep that in mind.
I'm gonna tell my roommate.
She takes chewable vitamins? Does she pay her own taxes though?
Yeah.
Okay.
I think so.
You think so? I would check on that, but don't let her know. Just like really dig into her financial history, and also just like rifle through her wallet. Pull out money.
I think she does.
You think she does?
Yeah.
You see a lot of like tax documents floating around. Maybe she's a business major.
I mean, I told her that we needed to file taxes, and she goes, "Don't do it yet, because we get a stub from church for like tithing or something." And I was like, "Okay." So she's on top of it more than I am, so.
Okay.
I'll tell her to stop eating vitamins though.
Good. So there are a lot of ways. So most of you have taken some oral medication. Most of you have also had some medications, or at least received. Yeah, you've received some sort of substance in another route. I'm assuming most of you have had immunizations. That's kind of a requirement for like a lot of schools, right? You guys probably had to provide proof of immunizations to attend Marshall. Is that accurate? Yeah. So there you have that. Distribution. How are we going to distribute this in your body? Hey, how many of you have a blood like a blood system? Okay. Yeah. Some people think they don't. It's like sand flying through there. That's a great way. Your blood vessels go just about everywhere, right? And if you don't believe me, try randomly cutting places on your body and see if blood comes out. And if it does, you know your blood vessels go there. If not, then so like your hair, if you cut your hair, you don't bleed. If you do it right. Some people, it happens. So blood's going to go everywhere. We can get drugs everywhere, riding that vascular system. That's pretty awesome. What we mean by metabolism is actually breaking down that drug, right? So you're going to take a drug, you're going to take a substance, and it's going to float around in your body for a while, and eventually it's going to collide with some enzymes. And those enzymes are going to rip that drug to pieces, literally. Jason, this is how it works, right? And when it rips it to pieces, guess what you have? Not the drug, right? You don't have what you had before, and so it's no longer going to be active. Here's a little side story. Sometimes you take drugs that aren't active, that when they are metabolized, they become active, and then you have to metabolize them again to make them inactive. So there's like sometimes that extra step. But for the most part, you're going to take a drug, it's going to be active, it's going to be broken down, it's going to become inactive, and then, how many of you have kidneys? Eric, some people may only have one. I said kidneys with the plural, so people only have one kidney. It's going to be excreted in your urine. Remember that funny colored urine that we had? Okay, so we're going to dump out these metabolites. Typically it's going to be through your urine. Okay? So urine typically only has 2 or 3 things in it. It's mostly water, salt, and then urea. That's like a nitrogenous waste in your body. If you have some other ions you don't need, you'll dump them out occasionally there, but that doesn't happen a lot. If you're diabetic, quite often there will be glucose in your urine. Or if you have high blood pressure, then you'll have some protein in your urine as well. If you take a medication, the metabolites of that medication will be in your urine. If you take something that's not a medication, the metabolites of that can be in your urine. Right? How many, you don't have to answer this, how many of you have ever worked somewhere where you had to take a drug test? Yeah. And a lot of times it's just urinating in a cup, right? I mean, that's a pretty standard test. And they're looking for metabolites because that's the main exit route. Okay. Questions about, in general, these 4 processes? Because we're going to spend a lot of time talking about a couple of these. All right. Let's talk about routes of administration. 2 full slides. Look at that. Okay. Jasmine, there are a ton of ways to get drugs into your body. Right? Some of these we think about, some of them we don't. Why do we have multiple routes of injection, or multiple routes of administration? The reason for this is some drugs only come in certain forms. Some drugs don't survive particular environments in your body. And sometimes we need to alter the speed with which a drug is being absorbed, right? Eric, sometimes we need to get it there faster, sometimes we want to slow it down. How many of you have taken or seen something called an extended release tablet, right? So this is something that's going to be a longer sort of maintenance kind of thing. It's extended release, going to last longer. We're not really worried about that like acute hitting something fast, right? So let's walk through each of these. How many of you have heard of an intravenous injection, an IV, right? A lot of folks have had IVs. If you didn't have one, your mother probably did. She might have had one like shortly after you were born, right? They'll give people IVs sometimes. What comes through an IV, common thing to give somebody in an IV is glucose. Right? That's a pretty common thing, but you can inject other things in there as well. So that's always fun. Why would we use an IV injection? If the whole point of this is to get the drug into your blood, getting it directly into your blood, that's like fast, right? So an IV injection is going to be super fast. Okay? We're not going to have to worry about how many of you have stomach acid? Yeah. So we're not going to have to worry, Travis, about that hydrochloric acid breaking down the drug that you're going to take, right? Okay. If the drug is particularly sensitive to hydrochloric acid and you swallow it, it's probably not going to do you any good. It's going to break down before you're able to distribute that, right? We also have injections that are called intraperitoneal or IP injections. This is just sort of into the abdominal cavity, right? So we might give an injection into the abdominal cavity. The concern here is it's going to be a little slower to be absorbed, right? So we're going to have to absorb this into the blood supply as opposed to that IV injection. It's going to be kind of super fast. We also have intramuscular injections. How many of you have had an intramuscular injection? How many of you have had a flu shot? Yeah, that's intramuscular, right? They'll stick that in your deltoid. Okay. How many of you have ever had one of those injections and it burned? Yeah. So, Jared, the reason it burned is because the pH of the drug that they're injecting in you didn't match the pH inside your arm. And there was a little bit of a mismatch there. And it had a little burning sensation. It happens. It's normal. I mean, if it continues to burn for like 6 weeks, see a doctor. Up until then, you're okay. So, intramuscular injections. Those happen quite often. You'll get those in the arm or the buttocks, right? That's kind of the other target for intramuscular injections. Although some folks also in the thigh, right, is a target as well in the leg, such as like EpiPens. Yeah, what's a good place to shoot yourself with an EpiPen? Like in the face? No, in the leg, right? So that's going to be intramuscular. Yeah, don't go around shooting people in the face with EpiPens. They're too expensive. Get something less expensive for that. Subcutaneous, this is going to be under the skin, right? So you're just going to go kind of under the skin, do an injection like that. Okay, that's not too big of a deal. We've talked about oral administration. We already talked about that, right? So it's just like swallowing pills or liquids, right? Robitussin, anybody ever taken Robitussin? I mean, it's a fairly common substance, right? Some cough medication. Sublingual. That's going to go under the tongue, right? There are things you can give people under the tongue. Sublingual. This is, this and some of the other things that we're going to talk about are sort of similar in that they're going to be absorbed through mucous membranes, right? And so they kind of have that sort of absorptive process through a mucous membrane, right? And that's going to get into the blood supply pretty quickly. Intrarectal administration. Quite often the reason you would give someone something through this route is like a nausea medication, right? So if you're nauseous and you're vomiting, am I going to give you something orally? It's not going to last very long, is it? It's going to go right down, it's going to come right back up. But if you were to put this in somewhere else that maybe you don't have things so freely flowing from, you're going to be able to hang on to that medication long enough for it to be absorbed. The colon is particularly good at absorbing things, right? Your intestine in general, the job is to suck nutrients out of the things that you eat, right? So you're right there with all kinds of little absorptive cells and blood supply and things, right? So taking some medication that way is a fairly effective way to do that. Inhalation. This is different than snorting, and I like to point this out, right? Inhalation is breathing something into your lungs and absorbing that through, right, through your lungs, okay? Snorting is different, right? When you snort something, it's actually going through a mucous membrane, so it's going to be similar to any of those other sort of mucous membrane applications, right? How many of you have ever had a nosebleed? That's pretty common. That's because the blood vessels are right there near the surface, right? The capillaries are, okay, in your nasal passages. So when you take a drug in through your nasal passages, it's going to be able to interface pretty quickly with the blood supply, right? Because you have all those capillaries there at the surface. You're going to be able to absorb through that mucous membrane the substance, whatever that is, right? Most of the time we don't think about snorting things that are legally prescribed, right? Although some of you do. How many of you take Flonase? Yeah, Eric, that's a snort, right? That's not, you're not inhaling it. You're not down the lungs, right? It's going up into your nasal passages and it's going to be absorbed in that way. So a lot of allergy medications are things that are snorted, not inhaled. There's also topical administration, right? How many of you have ever used Icy Hot? Yeah, and not as a prank, but like as an actual, like, my elbow hurts, I'm going to rub some Icy Hot on it, right? That's a topical administration, right? You're going to rub the medication. Lidocaine, for example, has anybody used lidocaine? They're putting that in some of the medications now, the topical creams and things. It's the same idea. So those are all pretty normal. We're used to most of those. There might be a surprise or two there that you weren't familiar with. The next two are not really common, and that's intracerebral or intracerebroventricular. This is when we're going to put something directly into your brain. Okay, I'm going to take a leap here and assume that most of you have not had drugs administered this way. Okay, most of you have not had a hole drilled in your head and someone squirt drugs in, right? I mean, that's not a real common way to get drugs. Okay, you might want to do this for a few reasons. The number one reason is, who remembers the blood-brain barrier? Okay, all of these other methods of administration require you to be able to pass the blood-brain barrier to have an effect on the brain. Okay, so Elizabeth, if we're not able to get past that blood-brain barrier, but we need this drug in the brain, then we're going to have to use one of these other two methods. Okay. I would not recommend doing something that requires you to have intracerebral or intracerebroventricular administration of a medication. Try to avoid that.
What would be something that you would need that for?
Yeah, so if you needed to get some antibiotics in there pretty quickly, you know, might be an issue. If you needed to get some anti-inflammatory medications, you might decide to go that way. Those are some possibilities. Matt?
Is that? It's not like directly in the brain, right? It's just like in the.
If you go with an ICV, that's going to go into the ventricle. So you're going to put it into that sort of fluid-filled space. Intracerebral, yeah, you're not just like jabbing someone in the brain, right? But you still need to you're going to be past that blood-brain barrier, right? So you're going to be in the blood supply that's on the other side of the blood-brain barrier. You're still going to you're going to have to get past that section to actually get into kind of the space around the brain. I would not recommend like jamming things into your brain tissue. Somebody's going to try that. All right. Here's a nice graph measuring cocaine in your blood plasma over time. This is showing you the various routes of administration, right? So here we have IV, we have inhalation, we have oral administration, and we have intranasal, right? So snorting. It will show you, these are all sort of adjusted so that they're comparable doses depending on the route of administration. But you will see the concentration of cocaine in your blood plasma. This is kind of at time 0, so this is at the time of administration. And how long that takes, how long that lasts. This is over several hours. Obviously, an IV injection is going to give you the most rapid and most powerful increase, right, in blood plasma. But notice that intranasal is sort of right behind that, right? So that one's actually gives you a pretty high sort of concentration. Right? Smoking, pretty rapid, right? Because to get into your lungs, your blood supply is right there. That's the job, right? The job of the blood flow coming through your lungs is to pick up oxygen, right, and to drop off carbon dioxide. So it's a pretty rapid process. So you're going to pick up those molecules and drop them off, get that in your blood supply pretty quickly. Oral administration, that's going to take the longest. I mean, look, you're talking almost like 40 minutes before you even start to see any increase in blood plasma, right? Cocaine in your blood plasma. So just to give you an idea, I know most people aren't thinking about cocaine necessarily, you're thinking about other kinds of drugs, but this is a pretty good example. Questions about that? All right, don't worry about this sentence. We do want to think about metabolism and excretion. These sort of go together, right? So we've already talked about absorption. The next thing is just distributing that through your blood supply. Right? That's going to be the standard for any route of administration. Once we're in the blood, that's going to be the same process, right? Doesn't matter how we got to the blood. Once we're there, then we're going to distribute through your body. If we're thinking about things that are going to affect your brain, we think about like how long does it take to get up to your brain. It doesn't take very long at all, right? So we're going to be up there, we're going to be fine. All right. We do need to inactivate and we do need to excrete things. Most of the enzymes that are going to deactivate drugs are going to be found in your liver. That's probably not a shocking story to you, right? I mean, it's probably a story you've heard before. You're going to create these enzymes in your liver. You're going to deactivate the drugs, and you're going to be able to excrete those. There are genetic differences in enzymatic function, right, across individuals. Some of you may have had gene assays, right, or enzyme panels to determine if how well you can break down particular drugs or drug classes, right? That's a thing that folks do sometimes now in medical treatments. Some of the enzymes that we'll talk about, well, I mean, how many of you have heard of alcohol dehydrogenase? That's pretty standard. Breaks down alcohol, right? It's formed in your liver. Not too big of a deal. Takes alcohol, makes it into not alcohol. Doesn't really matter what the metabolite is, but it's not alcohol. So it's not going to have an effect, right, Jason? So it's not going to affect your body anymore. These drugs are eventually going to be excreted by your kidneys. Now, this is sort of an important concept. To be excreted by your kidneys, these metabolites have to be less lipid soluble than the drug itself, right? And that's because your kidneys are made out of lipids, okay? And if your metabolite is lipid soluble, it's going to slip right through your kidneys, and it's going to slip right out of your bladder, and it's going to go back into your body, and it's going to do stuff, right? So we need something that's not lipid soluble, so it'll be contained in your kidneys, and we can actually excrete that and get that out of your body. So, any questions about that? All right. Now, how many of you like to take drugs that are effective? Yeah, that's a fair, you can admit to that, okay? That's not going to get you in any kind of trouble. No one likes taking a drug that's not effective. It's a waste of time, it's a waste of money, right? Waste of resources. So how do we figure out if a drug is effective? What makes a drug effective, right? Think about those things. How many of you have heard of dose-response curves? This is a curve, not in a road, but on a graph, that plots the dose against the response. Okay? How many of you have ever ingested caffeine? Yeah, okay, that's happened. How many of you have ingested a lot more caffeine? Yeah, what happened? You get jittery, right? So you had a more profound effect, right? So you take a little bit of caffeine, you know, I don't know, let's say 25 milligrams of caffeine, for example. What's that going to do to you? Oh, man, you know, you might have a slight increase in your heart rate. You're not going to. You get up to 100 milligrams of caffeine. You get up to 200 milligrams, 300 milligrams, and the next thing you know, your eyes are twitching, right? Everything's vibrating for some reason. You can see it. You can tell because you see these people walk out of Starbucks. They're just. And this is the whole trick behind Starbucks. They put so much caffeine in there, they make you spill your drink, so you have to come back and buy another one. It's a brilliant business model. Wish I'd thought of it. I hate Starbucks. Only because I didn't think, you know, of $8 cups of coffee myself and realized that you all would buy them. Had I thought of that, Eric, I probably wouldn't be working here. I would be not working because I would, you know, I don't know. Because out of every $8, I don't know, how much is Starbucks coffee? Is it $8? I made up a number.
It's pretty expensive.
$5, $4 to $5? Yeah, you probably get 75 cents worth of coffee.
For just black coffee, it's like $2 something.
Oh, really? For black coffee, it's $2?
It's for grande, it's $2.09 with tax.
$2.09 with tax. She's got her receipts for taxes. I thought you said you weren't on top of that. Got a nice budget there. Okay. Dose response curve. We're going to graph the magnitude of the effect of the drug as a function of how much drug you take, right? That's it. So for caffeine, if we want to measure heart rate, for example, right? That's a pretty objective measure of how effective is caffeine, right? Because caffeine will increase your heart rate. Over time, we give you more caffeine, you know, the higher the dose, the more your heart rate goes up. To a certain point, right? Like, what's the highest heart rate you think you can achieve, Eric? 600 beats a minute? No, I know. That's not going to happen. You know, maybe 200, right? You know, that might be, and I wouldn't recommend hanging it out up there forever, right? It doesn't matter, you know, once you take a certain amount of caffeine, your heart rate's only going to go so high, right? So even if you take 400, 600, 800 milligrams of caffeine, your heart rate's not going to exceed a certain limit, right? So this dose response curve will plateau at a certain point. We'll see what that looks like in a minute. Now, there's a thing called the therapeutic index. This is important. For our purposes, we're going to think about drugs that we're going to give you to make you feel better. Okay? And for this, we want to know what's the therapeutic index on this. How many of you are familiar with side effects? Yeah, all medications have side effects, right? Some of them are more severe than others. Some of them are more likely than others with side effects. The main side effect that we're going to think about for the therapeutic index is death. That's a pretty profound side effect that most of us want to avoid. And especially if you're trying to sell someone a drug that's supposed to make them better, you don't want to kill them, right? That makes sense. So this therapeutic index, and it can vary where you set these thresholds. For this case, we're talking about, what is the ratio between the dose that gives you that desired effect in 50% of the animals that you're going to test, because we're going to test this in animals, and the dose that's actually going to kill 50% of the animals. Okay? So if I give you 1 milligram of caffeine, that's not going to do anything to anybody, right? How much caffeine do I have to give you to increase your heart rate? That's what I want to do. I want to increase your heart rate. So how much caffeine do I have to give you to increase your heart rate? But how much caffeine is so much I might kill you, right? Caffeine, we're going to imagine that doesn't really happen. But we can think about this with, what's a more profound drug? How many of you have heard of morphine? Okay. There are wonderful applications for morphine. Pain relief, right? Let's say you're having a major surgery. Let's say you've been involved in a severe accident. Giving you some morphine is probably a decent idea, right? How much morphine do I have to give you, Ray, so you start feeling less pain? That's the effective dose, right? Okay. And that's what you want, right? Why would I give you less morphine than is required to relieve your pain? That's just stupid, right? Okay. The other thing you want is for me to not give you so much morphine that you die, right? You want somewhere between I feel better and I'm dead. Okay, that's the target range. Okay, that's where we want to be when we're giving someone a drug. Now, Abby, for some drugs like ibuprofen, what is the therapeutic? How wide do you think that therapeutic index is? It's pretty wide, right? Like, how much ibuprofen do you have to take to kill yourself? It's sort of like an infinite amount, right? So much that you actually are like choking on the pills because there's no room left in your stomach, right? Okay, because ibuprofen is not, it's pretty safe. So you take a couple pills, you can take 100 pills, you're not going to die, you're going to feel better, but you're also going to plateau, right? Taking 100 pills is not going to give you that much pain relief. Take a couple and move on. A drug like morphine, on the other hand, has a pretty narrow therapeutic index, right? Okay. The amount I have to give you to get you to feel better is actually not that much less than the amount that I would give you to kill you, right? If I were trying to do that. Because of the side effects, there are more powerful side effects on morphine, one of those being you stop breathing. Okay, so that's a pretty powerful side effect, right, Travis? I mean, so there you go. Now, this 50-50 number, some of you might think, well, that's kind of loose, right? For most purposes, like if we're actually going to try to take a drug to market, you might make this 95-5 or 99-1, right? Like, what's the dose that I need to give you so that 99% of you feel that drug effect and only 1% of you die? Okay, like what's that margin? That's probably better, right? Because how many of you want to take a drug that gives you a 50-50 shot at feeling better? That doesn't seem like it's really worth my time, right? It's like a lot of money for a 50-50 shot. I'd much rather have like a 99% chance that it's going to work. Okay, so that's good. And how many of you want a 50% chance that you're going to die? Like 50% chance you're going to feel better, 50% chance you're going to die. That doesn't really seem like that's going to be great. But 99-1, most people will take those chances, right? Man, that seems not bad. Like 1% of people who take this drug die. Still sounds like a lot, right? I'd like to introduce this concept of affinity. And we'll talk more about this later. Affinity is the readiness with which two molecules join together. And that's a pretty standard definition. What we mean by this is, when you take a drug, how likely is that to bind to its intended receptor? And how strongly does that bind, right? If it has a higher affinity, it's going to bind more strongly. It's going to have a more profound effect on the activity of that receptor, on the activity of that ion channel, for example, and on that cell. Things that have lower affinities, okay? Things that have a lower level of affinity are not going to be as powerful. Now, this runs us into a situation where we have endogenous versus exogenous molecules, right? And those endogenous molecules are the ones that you make. dopamine, for example. You have endogenous opioids, right? Okay, that are going to help mediate pain when you experience that. And those have a pretty high affinity for your opioid receptors. That's how they work, right? But there are some really brilliant folks out there that can design drugs that have an even higher affinity for your receptors than your endogenous molecules, right? So synthetic opioids are an example of that. So if you think about a lot of these synthetic opioids, the affinity that they have for opioid receptors is unbelievable, right? And their ability to latch onto that receptor and create that powerful effect, right? So think about what are prescription painkillers, right? Those seem to be like a pretty big problem right now. And part of that is because they are intentionally designed to be more powerful than the endogenous opioids that you have, right? So Colin, let's imagine you have an elbow injury. If your endogenous opioids work just as well as OxyContin, are you going to take OxyContin?
No.
There's no need for it, right? Okay. But if they don't work as well, then you're going to take some other prescription medication, right, to help with that elbow pain. So that seems reasonable, right? So there you go. I don't know. That's something to think about. Affinity explains everything. Well, I mean, at least with this. I wouldn't try to use it for other things, but at least in terms of drug action. That's why I think you see such a problem with synthetic drugs, right? Because they are specifically designed to have a more powerful effect that's going to increase the likelihood, Regan, that they're going to be addictive, right? Because they're designed that way. I don't know that someone who designed OxyContin would say, yeah, I designed it to be addictive. They just designed it to be more effective, right? And sort of the byproduct of that is, because it creates a more powerful effect, it's better at alleviating pain and has those other sort of effects, then it's going to be a preferred substance over something that's not as powerful, right? So that makes sense. Any questions about affinity? No, it's not too bad. Hey, what's this? This is a dose response curve. Okay? We can imagine this is caffeine. You give somebody a low dose of caffeine, you have a slight increase in heart rate. As you increase the amount of caffeine, you increase heart rate up until that point where you're going to plateau, where it doesn't matter how much more caffeine you take, you're not going to get your heart rate above, whatever that point is. Does that work? You could imagine this was morphine. You give somebody more morphine, you have a greater alleviation of pain, up until the point where you kind of reach a plateau. It doesn't matter how much more morphine you take, it's not going to alleviate the pain any better, because you're going to kind of tap out your receptors and so forth.
So taking a drug reoccurringly, does it, especially if it's something produced in the body already, prolonged, if you take it for such a long time, doesn't your body stop producing it and rely on the drug?
So we'll talk about tolerance mechanisms here in just a moment, yeah.
Like melatonin, for example. Like people take melatonin to sleep.
Yeah.
No, they stop taking it, they can't produce it on their own. So I just don't know.
Yeah, that is a real concern, actually. So when possible, let your body do what it should. There are times where that isn't possible, right? So you got to go other ways. Keep in mind that, and again, we'll talk about, I have like several slides on tolerance mechanisms, we'll talk about that. And there are a lot of things going on. So production changes, receptors change, enzymatic activity changes, all of these things. This is sort of melatonin's got its own problems. So I typically don't recommend people take melatonin. There was a study a few years ago with rodents where they gave mice a bunch of melatonin, and they noticed there was like a shrinkage of their gonads. I got everybody's attention. Stopping that. And for those of you that don't think you have gonads, you do, right? You just may not be able to see them, right? Because some of them are internal. Like one style you can get are internal, and one style are still technically internal, but you're kind of on the outside, right? You can see those. They're still important to keep them at their appropriate size because they do stuff like make hormones, right? And they keep your body doing the things that they should do, right? So if you got those internal kinds, you don't want to get like osteoporosis, so you don't want to like preemptively shrink them and reduce their activity. So there you go. That makes sense, right? So there's the heads up on that. But like this, speaking of testosterone, for example, right? Like lots of folks will take testosterone enhancing or boosting substances, right? And so this is actually, there's like this big wave of like supplements, right? Like increase your testosterone level. Well, I mean that's fine, you know, and you might get some like increase out of that, but at a certain point, your actual testosterone level is not going to infinitely increase, right? You're going to reach a threshold, and you're actually going to stop producing your own endogenous testosterone as much, and you're just going to be relying on that exogenous testosterone that you take. And then when you try to go off that, you're going to even make less testosterone than you did before, which is probably going to be counterproductive on what you were trying to do. So there you go. Does that work? If you want people to think you have more testosterone, just get a fake beard, right? Just glue it on, and you'll be good to go. just peel it off, yeah. Peel it off when you know. Anytime you want to eat, just eat in private, and you don't get stuff stuck in your beard. Stick it back on with some spirit gum, right? Anybody a theater major? Spirit gum is like facial adhesive. Tossing that out there. All right, so there's your dose response curve. Not a big deal. Not going to continue to just skyrocket all the time. There is going to be that plateau, right? Okay. All right, here's the dose response curves for morphine. This is your, that gives you that analgesic effect. That's the pain relieving effect. Here's the one that has the sort of depressive effect on respiration. That's the one that'll kill you. The gap here is what we call our margin of safety. This ratio is going to be our therapeutic index. The wider these two curves are apart, the farther they are apart, the safer the drug, right? The closer they are together, the more likely you are to die from it. Okay? Because what would happen is if the curve, for example, is here, right? And then you want to give somebody like a dose to alleviate this much pain, I mean, look, it kind of intersects with that like you're going to die curve, right? And so there's like a chance, Eric, that if you take that much of that drug, it'll kill you. If these curves don't overlap at all, then you're better, right? So that's good. Something like Tylenol, for example. Here's your effective curve for Tylenol. Your death curve for Tylenol might be out here, right? Pretty wide gap. All right, questions about that? It's not horrible, right? Hey, check this out. Let's talk about some tolerance. So, some folks take medications repeatedly. And that sets up a mechanism called tolerance. And then later, when you try to go off that drug, we can think about withdrawal mechanisms. Okay? So if we're thinking about tolerance, over time you have to take more of a medication or more of a drug to achieve the same effect, right? So this happens with individuals who take illicit drugs, cocaine for example, right? So if you are, if you're on cocaine and you're taking cocaine over time, initially you're going to take a smaller dose, and then you have to take a slightly larger dose, and then a larger dose. And over time you have to continue to increase your dose to have that same perceived effect, right? That same feeling of that. It doesn't just happen with things like cocaine. How many of you have heard of L-Dopa? This is a standard treatment for Parkinson's disease. It's a precursor to the neurotransmitter dopamine. Okay. Quite often they will give people with Parkinson's disease L-Dopa. Seems reasonable. If you're losing dopaminergic neurons, you're losing those neurons that make dopamine. Let's give you more dopamine. That should help, right? The problem is over time you need to increase that L-Dopa dosage, right, as they're continuing to lose the ability to make their own dopamine in some of those cells. So they develop some tolerance to that as well, in a slightly different way. So how do we develop tolerance? Well, there are a couple ways. One has to do with enzymes. Remember those enzymes we were talking about in your liver? Okay. When we think about, for example, alcohol dehydrogenase, how many of you are familiar with that? Because I just told you about that, right? So you should be familiar. So we're good. So alcohol dehydrogenase, right? If you do not drink alcohol at all, your alcohol dehydrogenase levels are pretty low, right? Okay. And so if you were to drink a little bit of alcohol, you would have a fairly, let's say, moderate, reasonable effect from that, right? Because you don't have any alcohol dehydrogenase. If you're someone who is a, I don't want to say heavy drinker, because that sounds bad. I'm almost raise their hand on that, right? Maybe you're someone who enjoys, you know, an alcoholic beverage a couple times a week, right? So your alcohol dehydrogenase levels are going to be a little higher, okay? Right? So the enzyme level is going to be higher. If you were to have, you know, a glass of wine with dinner, it's probably not going to have much of an effect on you, right? That alcohol dehydrogenase this is one mechanism why it's not going to have much of an effect, right? Because that enzyme level is going to be higher. Okay. We also want to think about receptors. Neurotransmitters do their work through receptors. Remember we talked about metabotropic and ionotropic receptors, right? Now, if I have a lot of receptors, they can all be activated. They can all open ion channels, and that can cause a profound effect in my neurons. Over time, I've been taking a drug that's having this profound effect, right? And I'm constantly fighting for something called homeostasis. Constantly fighting for this sort of basic level, wherever that is, this basic level of activity, right? Anytime I get above that or below that, I'm going to do some corrective mechanism internally to try to come back to that baseline level, right? The problem is if you're taking something like cocaine, you're fighting against that, right? You're trying to override that baseline level of dopamine activity. You're trying to jack it up really high so you get that good feeling all the time, right? So you have that kind of awesome, I feel great. Okay. One way that we'll try to compensate for that is we'll decrease the number of receptors that we have for dopamine or any other neurotransmitter that's being affected. Okay. By decreasing the sites of action, we're decreasing the places where dopamine can have its effect. And when we do that, even though you're flooding the synapse with dopamine, because you've been taking a drug that does that, that's inducing the release of dopamine. We've got fewer places for that dopamine to latch onto, open, and affect the activity of that cell. Okay? That's why you're developing that tolerance. So then what you have to do, you have to increase your dosage, right? You have to increase the dosage of whatever drug it is that you're taking so that you can overcome the fact that you're losing receptors. Does that make sense? This takes a little bit of time. That's reasonable, right? Takes some time. The time course is going to be different for different drugs, different amount of drugs that you're taking. It's going to be different based on your sort of own genetic and enzymatic environments, right? So it can vary from person to person. So that's understandable. Once you've been taking that substance for an extended period of time and you've developed tolerance to that, whether you've decreased your receptors or you've decreased your or increased your enzymatic activity or you've decreased endogenous production. Okay. Whatever it is you've done to try to fight back to that homeostatic level, that's going to be a relatively sort of permanent and long-lasting solution, right? And when you go off that drug, Jason, your receptor levels, your enzyme levels, your production levels are not going to instantly snap back to that normal homeostatic level. If they did, we would never have to worry about relapse. Well, we'd have to worry about relapse a whole lot less, right? So, like, what's the number one reason someone will relapse on a drug? They don't want to go through withdrawal. Have you ever, and you don't have to answer if you've been through withdrawal, have you ever heard someone say, wow, geez, I can't wait to go through withdrawal. That sounds like fun. Or if you've been through withdrawal or know someone who has, they say, that was the most fun experience I ever had. I loved sweating and feeling bad and curling up in the fetal position and thinking I was going to die. That was just phenomenal. No, nobody says that, right, Eric? I mean, no. And so quite often, what people will do is when they've been on a drug for a period of time and they try to go off that drug, they'll do it for a little bit. And then they start feeling so horrible, the only way to alleviate that is to go back and take the drug again, right? And so it's kind of this constant back and forth sort of process, right? How many of you have known someone who's gone through that sort of same process, right? Where they've tried to quit something and then they can last for, they get into that withdrawal period and they're like, oh, I can't take this anymore. I have to, I have to alleviate this horrible feeling. Think about relapse. Sometimes withdrawal is actually deadly. Can be, right? Especially with alcohol, for example, right? So typically they won't recommend you to just like, if you're an alcoholic, they don't typically recommend that you just like stop drinking cold turkey. That's not a good idea, right? Because that actually can be fatal. And a lot of that has to do with the tolerance mechanisms. Because you've been taking this alcohol for so long, which actually works on your inhibitory neurotransmitter system, you sort of remove the brakes, the natural brakes that your brain has, right? And when you remove that alcohol, you don't have those brakes anymore, right? And so those inhibitory processes are no longer present, only excitatory processes, right? And you can actually have some serious side effects, including death. So that's something to watch out for. That's not my recommendation for you to continue drinking. I just want to be clear, find some help. And there are ways you can kind of ease yourself down. Not recommend trying that on your own. All right, who's heard of placebo effects? These are fun. Yeah. How many of you have ever experienced placebo effects? How many of you have ever had your mother kiss a boo-boo and make the pain go away? Nobody's going to admit to that. It's like, no, never. How many of you still call your mom and say, no, nobody does. We got one person that's like, I stubbed my toe yesterday. I went home. No, that's fine. You can do that. Whatever. But placebo effects actually work, right? I mean, this is one of the reasons it's so difficult to get like depression medications to market, because placebo effects for depression are just about as good as the medications, right? So they'll do these sort of clinical studies, right? You've developed some kind of drug and you think it treats depression, and so like awesome, the chemical process looks like it's going to work. The next thing you have to do is you have to do some animal studies. So you make some rats depressed, you give them the drug, and then they start getting better. And they're like, well, they're not depressed rats anymore. That's awesome. So then you think, well, okay, let's do this with people. So then you find some depressed people. You don't make the people depressed. That's not nice. So you find some depressed people, and you think, all right, so some of you I'm going to give the drug, and some of you I'm not. Some of you I might give you just a pill. Keep taking it. I mean, it might be good. It might not be good. Some of you, I might even just have you like sit down and talk to somebody. They always do the like a standard sort of control group is the what they call it, the kindly professor. They make you talk to some guy in a cardigan and he just acts like he listens to you. I think, and some people actually get better from that, which is interesting. When you go through these studies, most of the drugs that like made rats kind of not depressed anymore don't work any better on people than just going through sort of a talk therapy situation, just going through other sort of actions or behaviors, or a placebo effect. And if that's the case, we're not going to run the risk of giving you a drug that has potentially fatal side effects if it's not going to really make you any better than just sitting down and talking about your problems. Because that doesn't really have too many side effects, right? It seems like a safer option. Okay. And if we think about that dose response curve, we think about that therapeutic index, right? How many of you have ever seen a commercial for an SSRI? They're relatively safe. But how many of you have seen those and they still have side effects? You think, well, I don't want any of those. But, you know, in those cases, that particular drug has exceeded, by some measure, sort of other approaches, or non-medication approaches, at least, to alleviate those symptoms. So, placebo effects are real. These can be based on, you know, a lot of external factors, expectations. Again, we often use this as a control group in research, right? So there you go. The next time you have the flu, how many of you have ever had the flu? Just tell yourself you don't have the flu and see what happens after. Placebo effects don't really work for everything, right? So I would not recommend like trying to cure the flu with placebo effects. These are two very important concepts. And we're going to spend a lot of time talking about these. We're going to talk about agonists and antagonists. If something is an agonist, and here's kind of the fancy phrase, it's going to facilitate postsynaptic effects. Okay. Well, what does that mean? An agonist will increase or mimic the effect of a neurotransmitter. Okay? Now, each agonist is going to be specific for a certain neurotransmitter. Okay, so you have dopamine agonists, you have serotonin agonists. Okay. We'll talk about details in a moment. On the other side of this, you have antagonists, and these will block or inhibit those postsynaptic effects, right? So they're going to decrease the effectiveness of a neurotransmitter, whatever that is. And again, you have serotonin antagonists, you have dopamine antagonists, okay? Do not get confused here, because this is what happens. When I say, hey, this is blocking, if I say it's blocking, that doesn't necessarily mean to you immediately that's an antagonist. We can block things that still facilitate neurotransmitter function. Okay, and we'll talk about that in a moment. So blocking or even exciting, we can excite things, but we can excite them in a way that decreases neurotransmitter activity, right? So we have this sort of, so we want to think about that, Elizabeth. We don't want to just go, automatically it blocks, that's an antagonist. Not necessarily. All right. So let's think about some of these sort of steps and things that can happen here. Agonists and antagonists can affect the synthesis pathway of neurotransmitters. We have to build these neurotransmitters from scratch. Okay? We're going to build them largely from amino acids. Some of them are going to be diet-derived amino acids, some of them are not. Serotonin, for example, is built from tryptophan, which is a dietary amino acid, right? You have to get that from things like turkey, right? That's why all Thanksgiving fights happen before dinner. Nobody fights in Thanksgivings after you eat the turkey, right? Because the tryptophan's kicking in and it's turning into serotonin, and everybody's happy and good to go. That's when all the making up happens, right? Everybody fights before, and then after the turkey. If everybody just ate a turkey sandwich on the way over, see, this is it'd make everybody happy when they arrive for Thanksgiving dinner. So that's like a pre-turkey turkey. Abby thinks that's a good idea for some reason. You like turkey sandwiches? I mean, just enjoy it. It's just a good sandwich. I mean, it's just a good go-to. Had a nice loaf of rye bread the other day. It's gone, so don't expect me to bring it and share with you. For those of you that like rye bread, I ate it all. No preservatives, so you have to eat it fast, right? So it's not going to last. So it was like a really nice rye. I had some turkey, some smoked Gouda, a nice thick tomato, and some lettuce. And I ate that for like 4 days straight because I didn't want the bread to go bad. And my wife doesn't like rye bread, so when I get a loaf, I have to eat the whole loaf. There you go. So neurotransmitters are synthesized by those presynaptic neurons. We already talked about L-DOPA. This is the precursor to dopamine. So if I give you a bunch of L-DOPA, you're going to be more likely to make dopamine because you have the precursor to do that. Okay, so that's not a big deal. Some drugs will deactivate particular enzymes in that pathway if there is a way that we can block a synthesis enzyme, right? Because there are enzymes that are going to make, there's an enzyme called tyrosine hydroxylase, right, which is in the dopamine pathway. And in the serotonin pathway, we have tryptophan hydroxylase, right? So we got to stick a hydroxyl group on the tryptophan there so we can get that into serotonin, make it into serotonin. If we block that, then we're not going to be making serotonin anymore, right? And so that's going to be an antagonist. So in this way, we are facilitating or blocking. It's agonist antagonist. In order for us to get a neurotransmitter out of one cell into the synapse and to affect another cell, we need to store it in what's called a synaptic vesicle. Okay, we've talked about these. It's basically just a sac of neurotransmitter. We can actually have drugs that increase the activity of these vesicle transporters, right? We get more vesicles down at the terminal so we can dump those out. There are some drugs that are going to block the vesicle transporters, right? When we block that vesicle from making it to the synapse, then we have acted as an antagonist, right? We've prevented that action. Okay? Some neurotransmitters can be inhibited or enhanced in their release, right? So there are some drugs that actually prevent the release of neurotransmitters. How many of you have heard of botulism toxin? Okay. Anybody had both? You don't have to answer. We'll know if you've had Botox.
I thought botulism was like when you eat something that's gone bad. Or
It is.
Yeah. Like
It is. But then they decided to make it into something to pull your face back. Same stuff. Same stuff. Also, it can, if you have sweaty armpits, it can kill your, not surprising, can kill your sweat glands in your armpits. So some people will do that. There are also some uses now for migraines, right? Which seems like a better approach, man. I'm okay with, like, you got a saggy face, just live with it, right? I'm not going to take a chance on giving myself botulism because my face starts to sag, and I'm just going to buy like better deodorant and an antiperspirant if that's the case. The other problem, on the other hand, if I have migraines that are like preventing me from looking around, yeah, I don't know. I might try botulism. Just give it a try. Anybody thinking about it?
I've done it. They take the needles, they go like all the way around, like
Yeah.
to the back. Didn't help.
Didn't help.
Well, there's that.
Well, at least you didn't die from it. So there's that, right? That's always, I guess, the positive side of it. But look for the silver lining. So there you go. If I get forehead wrinkles, I'm just going to start wearing a bandana. I think I'd look cool in a bandana. What do you think? Just like all the time. Nobody thinks that's a good idea. I used to wear a bandana sometimes. I mean, it's just, I think some people have always worn bandanas, right? Like periodically. At one time in my life, I wore a bandana. I mean, like once. All right. And some drugs can trigger the release of neurotransmitters. Alcohol. Alcohol is going to, cocaine will trigger the release of dopamine. Alcohol, we're thinking about inhibitory transmitters like GABA. This graph, or this particular diagram, is actually really nice, and it summarizes pretty much everything. This is in your book. I know it's, at least I'm sorry. It didn't translate well to this format. it basically outlines every possible place where an agonist or an antagonist could have an effect on the neurotransmitter pathway, right? So it's kind of cool. So here we go, number 1, that's like a precursor. We talked L-DOPA, not a big deal. Here's number 2, enzymatic, interrupting that enzymatic activity there. So that's not a big deal. Talk about storage in the vesicles, okay? Moving the vesicles down to the synapse, right? That's not a big deal. We didn't really talk about this like acting directly as an agonist, directly onto the receptor itself, right? So there are direct agonists and direct antagonists, right? That will actually open, direct agonist will directly open an ion channel, and antagonist will block that if it's a direct antagonist. The other thing we should talk about, so there's direct agonist, receptor blocker, talked about that. Non-competitive binding, this is actually something that's kind of important. How many of you have ever dealt with government contracts? There are competitive and non-competitive contracts, right? So if it's a competitive contract, that means multiple companies will submit a bid, and you can, based on whatever features you need, price is going to be an important sort of component there, but also the product that they're going to deliver, the service, and so forth. You're going to select the contract that's the best. Some are non-competitive. And that means somebody's already decided who's getting the contract, and no one else can put in a bid for that. And so that's who we're going with for this particular service or this particular item, right? We have a similar idea here in your brain. So we have competitive binding. This is when one neurotransmitter is going to be competing with another substance, right? They can kind of compete for that binding site. They're both going to be kind of good at getting in that binding site. Okay. We also have non-competitive binding. And Jason, this means that there's a substance, bam, and guess what? Guess what's really high for this substance if it's non-competitive binding? I'm going to slowly write it here for you in really giant letters. It's like Wheel of Fortune, you guys need to guess. See how long this takes. Affinity. Yeah, thank you. Affinity. If it's non-competitive binding, the affinity of that molecule for the receptor, that affinity is going to be super high. Okay? It's going to be so high that it's going to be locked in together and you're never going to rip them apart. How many of you know somebody like that? Like they're like so locked in with some other person that you can't pry them apart even though you hate one of them? Somebody sounds like they just choked over there. Are you like currently plotting to rip two people apart? You don't have to answer that.
No.
No, you're not. Okay. That sounded a little sinister, but that's okay. We've already started the plan into action, and the plotting phase is over. So, if the affinity is really high, we're not going to be able to dislodge that molecule, right? It's going to just be in there doing its business. Okay. And that could be an agonist or an antagonist. It can be in there so strong that it's not going to come loose. It eventually will, but it's going to take a while. Okay? Here you go. These are direct agonists, direct antagonists over on this side. Again, the drug is going to bind directly to that neurotransmitter site. Okay? Not a big deal. This is going to be competitive binding. They're both going to be headed for that same site. The drug and the molecule of the neurotransmitter are both going to be trying to get in there. Their affinities are going to be similar. The drug gets there, it's going to activate it. If the neurotransmitter gets there, it's going to activate it. You're going to have to be an agonist in this situation if you're opening. Right, because either way, if it's the neurotransmitter or the drug that gets there, then you're going to be opening the ion channel. So if you have drug that's going to open ion channels and neurotransmitter is going to open ion channels, the likelihood you're opening ion channels is increased because you've got another substance there that's doing that. If you've administered a direct antagonist that's also competing for that same site, well then you sort of got like a 50-50 shot, right? Is it going to be the neurotransmitter that's going to open this channel, or is it going to be the drug that's going to close the channel, right? And so you've got to, instead of now like, 100% probability of opening a channel, it's a 50-50, right? So it's 50% is going to open, 50% is going to close. If we're dealing with non-competitive binding, the neurotransmitter doesn't really matter. The neurotransmitter is still going to be binding to its own neurotransmitter site, but there's going to be another site where the drug can bind. And whenever the drug binds, it's going to override whatever the neurotransmitter was going to do. Now, this doesn't make too much of a difference when we're dealing with agonists, because if the neurotransmitter was there, it was going to be open. If the neurotransmitter and the drug are there, then it's going to be open, right? The drug may stay longer, so if the neurotransmitter leaves, then it's still going to stay open. Okay, that's fine. But when we're talking about an agonist and non-competitive binding, it's going to bind over there, and it doesn't matter whether or not you have a neurotransmitter present or not. Okay? We're going to still close that channel. So, non-competitive, the drug is going to override the neurotransmitter. Competitive, they're both competing for the same location. Okay? Questions about that? Awesome. You guys ready for the test? Next week? It's not next week. Just trying to... I know, right? I should put a disclaimer on this class. Please take an anti-anxiety medication before you come in. So there you go. Oh, hey, who loves reuptake? There are a couple ways that we can sort of end the effects of a neurotransmitter. Okay. One of these is going to be reuptake process, and the other is going to be enzymatic deactivation. These are going to be the two major ways that we can end the effects of a neurotransmitter. Reuptake is a process where the cell that has released the neurotransmitter will reach out and grab that neurotransmitter and pull it back in. Okay? Normal process. Drugs can interfere with that process. A particular class of drugs that interferes with that reuptake process is referred to as SSRIs. That's selective serotonin reuptake inhibitor. So guess what? If we work backwards, we're inhibiting the reuptake of only serotonin, right? And if we're inhibiting the uptake of serotonin, that means, where is the serotonin? It's at the synapse. And if the serotonin is at the synapse, what can it do? Serotonin-y things, right? Whatever serotonin does. It's going to open ion channels. That's what serotonin does. So if we use an SSRI, is that an agonist or an antagonist for serotonin? Elizabeth, this is where you have to think about blocking, not blocking, right? Okay. It's an agonist, right? Because we're increasing the amount of serotonin that's out there still and is staying longer, so we're increasing the effect of the neurotransmitter. Even though we're blocking a process, we're not blocking the elimination, or we're not blocking the neurotransmitter itself. We're blocking its elimination, right? So we're sort of extending the life of serotonin, and that means we're going to be an agonist and we're going to increase those effects. Okay? The other thing is going to be enzymes. So I want to think about enzymes a little bit. How many of you have heard of MAOIs, monoamine oxidase inhibitors? Okay? Yeah. This is monoamine oxidase is an enzyme that takes a monoamine, such as dopamine, for example, and oxidizes it. And basically what that does is that makes it no longer dopamine, doing this oxidase procedure. So you're not going to make it dopamine anymore, so it's not going to be effective. You're breaking it down into something else so you can recycle that and use it again later. So, if we are inhibiting the effect of monoamine oxidase, that means we are, again, increasing the likelihood that dopamine is going to be out there doing its business, right? Okay? Does that work? So that's pretty awesome. Questions about that? There are other enzymes. Another one you should know is acetylcholine esterase. How many of you have heard of acetylcholine? How many of you have ever used acetylcholine? Like not exogenously, but endogenously. You've used acetylcholine. Yeah, everybody does. How many of you have ever contracted a muscle? You've used acetylcholine. You don't know. I like that response, Jasmine. You kind of went like, I don't know, and then you had to contract muscles to do that. Sort of an ironic answer, but a good one nonetheless. So we do not want acetylcholine to stay active forever, right? Okay. So Eloise, I don't know what position you play. I'm going to take a guess at second base. No, not even close. Not even close, Abby. What is it?
Center field.
Center field. That's actually relatively close to second base. You just draw a straight line back. Okay, so center field, right? Now, have you ever caught a ball in center field? And when you do that, like the thing you need to do, and I'm going to obviously have some very sort of gross oversimplifications here, so please don't critique my technique. But it's going to involve, I know this much, putting your glove up in the air, right? That is a step involved in this, right? And so you're going to put your, and that causes some muscle. You've got some muscle contraction. You're probably going to have your other, you're supposed to have your other hand up there too, right? I know this. Because the one thing you don't want, I mean, there are a lot of things you don't want to have, but one of them is you don't want the ball to hit you in the face. So I'm going to tell you that's painful. So you're going to have your hand up. Now, you're going to have to eventually get your hand down, right? And if acetylcholine remains active forever at the synapse, unfortunately, or at this connection between the brain and the muscle, unfortunately your arm's never going to come back down, right? Because acetylcholine is just going to stay there, you're going to stay clenched. And that's going to be really difficult for you to get that ball to like maybe the second baseman, right? Is that you, Abby? No. That's good. Because if Eloise got stuck like this, because her acetylcholine esterase didn't work, you're going to be in a very awkward position. You're going to have to like run out there and grab the ball from her, which is going to be weird, and then you're going to have to try to throw it in to now no longer the second base, it's going to be the shortstop who's had to come, and then you've just really screwed up your whole system. So you want acetylcholine esterase to work properly. If you interfere with that, that causes some problems, right? It causes paralysis, as you could imagine, right? So there's another enzyme that can break down a particular neurotransmitter. Nobody ever, right, like before they never think about, they're like acetylcholine esterase fitness, right? I mean, you have like a fitness regime to increase your acetylcholine esterase so you can like move your, like I don't know, right? Nobody wants to do that. Think about these things. Or don't listen to me, because I don't know if you'd win any games. But it would be an interesting set of experiments that we would do. We would learn a lot, but not have a winning season if I were a coach of a sports team, because I would be trying things like this all the time. Instead of giving my players steroids, I would give them like shots of acetylcholine esterase before the game to see if it made them move faster, right? Because they could, like they're, I don't know. I'm thinking of this, right? But then what if they had too much and they could never contract the muscle? Like as soon as they tried to contract it, just their arms went limp again. That could be a problem, right? You guys should think about these things. Hey, here's an idea. Next time you have a game, try to mix a little acetylcholine esterase in the opponent's water. See if that will prevent them from contracting their muscles.
You don't like have open access to very many biology labs or anything, do you?
Just glad I don't know someone who works for West Virginia American Water. But try to put this in the water and see what happens. These are great ideas. You can do it with rats maybe instead, right? You can teach two rats to fight each other and then give one acetylcholine esterase and the other one not and see what happens. Nobody thinks that's a good idea either. It's a new wave of performance-enhancing drugs or performance-decreasing drugs, right? Nobody's working on the other side of that, Eric. Nobody's working to sabotage somebody else. That's a market that's wide open. Wide open. I don't know if anybody wants in on that. All right, let's talk about some specific neurotransmitters and neuromodulators. We should talk about a few things. There are 50, probably, give or take, neurotransmitters and neuromodulators. You're not going to have to know all of them, okay? I want you to know some basics about a few of them, so we're going to be fine. One of them is called glutamate. How many of you have heard of glutamate? Or its sort of other version, glutamic acid. Yeah, there we go, right, that's a thing. This is the main excitatory neurotransmitter in the brain. When we say it's excitatory, that means it opens ion channels for cations. What are cations? They're positive ions, right? They got that plus sign hanging off of them, okay? We're going to talk a lot about glutamate later in the semester when we talk about learning and memory. Interestingly, I don't tell you about learning and memory until, like, 3/4 of the way through the semester, after you've already been trying to learn and memorize things. And I tell you how that works. There are a couple kinds of receptors here. There is the NMDA and the AMPA receptor, right? One of these is for sodium ions, and the other is for calcium ions. That's like a 2+. That's one more than a 1+. That's on sodium, in case you hadn't thought about that. There are some metabotropic receptors. NMDA is pretty important for the learning and memory process, right? Those NMDA receptors. How many of you have ever heard of ketamine? Yeah, ketamine's a thing, right? There are some good uses for ketamine, like if you're a horse veterinarian and you need to anesthetize a horse, ketamine's a good way to do that. You can also use it in cats, dogs. A not so great way to use ketamine is as a date rape drug, just as a heads up there. Ketamine is what we call a dissociative anesthetic, right? So if you take ketamine, you're anesthetized, in essence, but you're not unconscious, right? You're sort of disconnected from your surroundings. You can still walk, you can still move around, right? But you're not really plugged into what's going on. This is why someone would try to give it to you, right? If they wanted you to, like, do things you didn't want to somewhere else, right? So they could give this to you in one location, and then you sort of, for all intents and purposes, appear as you did before, and then you can just kind of like walk arm in arm with this person, and you really don't know what you're doing, and you have sort of no way to resist that, unfortunately. And it's likely that you won't remember much of what happened either, because NMDA is important for that memory process, and ketamine interferes with NMDA receptors. So it's going to interfere with your ability to have a memory of that event as well, which becomes difficult when you get to a prosecutorial situation, right? So you should always bring a lid. Take it to the bathroom with you. Just get a new drink when you get back, right? So watch out for that. Questions about glutamate? Right now, that's kind of what you need to know. Plus a little life lesson there. The other thing that you might do with ketamine. Ketamine actually, we'll talk more about this later. There are actually folks who are prescribed ketamine for depression. It's sort of a short-term solution. They'll try to do ketamine long-term. It also works as sort of a good battlefield anesthetic. They will still use it in combat situations. The reason is if someone is injured and you give them ketamine, yes, it will sort of keep them from, it will interfere with their memory, so maybe the likelihood they develop PTSD later is decreased, but they have not lost their ability to actually walk, assuming that their legs aren't injured, right? So if they have like an upper body injury, for example, or something, you can give them ketamine. They can still use their own power to assist you in getting them out of that situation and into a sort of, a triage or hospital area. So in those cases, it's probably still has some good uses, right? I wouldn't recommend it for, like, day to day. They don't use it a lot for human surgeries anymore. Previously it was an anesthetic that you would sometimes receive if you were going in for an operation. But it's not used as much, if at all, really anymore. GABA. This is gamma aminobutyric acid, right? So you don't need to know all of that, especially since the first G is actually a Greek letter. Okay, so there you go. It is the main inhibitory neurotransmitter, It's produced from glutamic acid. Who remembers glutamic acid from like just that previous slide? It's produced from, I know because you're NMDA receptors, right? You got to have those going. And there's an enzyme called GAD that makes GABA out of that. Here are some GABA agonists, right? That will increase activity of GABA. Alcohol is also a GABA agonist. Benzodiazepines. How many of you are familiar with benzodiazepines? These are hefty GABA agonists, right? These are things you should only be on for a short period of time. If you've been on a benzodiazepine for an extended period of time, I would recommend asking about that and possibly seeing a different medical professional for that. You shouldn't be on those. Those are not good long-term solutions. They have some pretty heavy side effects. They do sort of, GABA, you can imagine, has some sort of anti-anxiety effects, right? You're kind of increasing that inhibitory activity, toning things down a little bit. Not a big deal. Here's that other neurotransmitter that we talked about, acetylcholine. Out in the peripheral nervous system, it's used for muscle contraction. In the central nervous system, which is your brain and spinal cord, right? It's going to be used for learning, memory. It's also going to play a role in sleep. We'll talk about how that works. It actually has a considerable role in what we call vigilance, right? So you're going to have a lot of acetylcholine in your cortex when you're awake. You're sort of vigilant looking for things. You may not think, well, REM sleep, which is kind of like a funky kind of sleep, right? We'll talk about that when we talk about sleep, but it's going to play a role there as well. Dopamine, that's another major neurotransmitter, right? Involved a lot in attention. In particular, it's involved in reinforcement, right? And think about that reward pathway as well, right? So reinforcement and reward, dopamine is going to be involved in that. Anything that you do that feels good probably increases dopamine levels in your brain, right? Such as coming to class. I'm sure that makes everyone feel great. Think about the dopamine spike you're getting every time you show up to this class. Think about the dopamine spike you're going to get when you get your midterm grade and it's not an F. Right? That's going to make all of this worthwhile, I promise. If you're going to get an F at midterm, I would recommend just not coming to class. Like if that's what you're planning for, like definitely just get an F in this class because stay home and play Call of Duty or something. I mean, it's a better use of your time. Right, Elizabeth? But you're not going to get an F, so you're here. We appreciate that. Hey, what about norepinephrine or epinephrine? Sometimes this is called noradrenaline or adrenaline, right? Anybody know why?
Spikes or lowers the heart rate.
Yeah, absolutely. And then it's made by that little elf hat on your kidneys, known as the adrenal gland, right? There's that little kind of like cap that goes on your kidney. And so that's anything adrenal, it's a kidney issue. Adrenaline is a kidney thing. Nobody thinks about like when you're having an adrenaline rush, right, Eric? Like, wow, my kidneys are working now. But that's the case, actually. It's like, wow, get my kidneys going. I'm going to get excited about this today. No, nobody thinks that way. Try it next time. Next time you want to, I always say, like, is your heart into it, right? Like, are you really excited about it? You say, are your kidneys into it, right? Nobody says that. Makes a lot more sense biologically. Your heart rate is just a byproduct of your kidneys. It's all kidneys. Epinephrine, norepinephrine, it's going to be involved in vigilance in the central nervous system. As Eric told us, regulation of heart rate, blood pressure, all of those other things that you feel when you get that adrenaline rush, they're going to be under control of that neurotransmitter. Serotonin, we've talked a little bit about this. Serotonin is used for a lot of things: mood regulation, eating, sleep, dreaming, arousal, and impulse control, right? We'll talk about all of these as we get to those different systems later in the semester, so not a worry. Histamine, that's involved in wakefulness. How many of you have ever taken an antihistamine? And then what happened? You took a nap. You fell asleep, right? How many of your parents have given you Benadryl because you're annoying? My parents still try it. I think the last birthday cake I got had some antihistamine in it. It's like, oh geez, we got to see this guy for his birthday. See what happens. Put him to sleep. He'll leave. Opioids, pain modulation, reinforcement. What about endocannabinoids? How many of you have ever heard of those? Yeah, you've got endocannabinoids. Appetite regulation. Not a shocker there, right? I think you should have been able to make that connection, that endocannabinoids were related to appetite in some way, right? Because exocannabinoids sort of have an influence on your appetite, right? This is why folks with like wasting diseases that cause you to lose a lot of weight, what's a good sort of medical approach is marijuana, right? Cause them to kind of stimulate their appetite.
Is that the satiety? Is that what that legislatively is?
Yeah, we got a whole chapter on eating, and we'll talk about endocannabinoids then, but in more detail. But yeah, absolutely. So there you go. We'll talk about other satiety mechanisms as well, like ghrelin and some other things. Not surprisingly, eating is a very complicated behavior, given its sort of importance for your survival. There are a lot of things that contribute to eating behavior, which is actually kind of fascinating. Most of you don't think about eating as a complicated thing, Jasmine, but it is. It's very complicated. Hey, here's that NMDA receptor I've been telling you about. Not a big deal. So far I've been talking about things that are what we call ligand-gated. This is actually an important concept. So what is a ligand? Well, it's just sort of a thing. That's a D, by the way. And in our case, we're thinking about it as a molecule, right? So when we talk about a neurotransmitter binding with a receptor, and it's going to open that ion channel, that's ligand-gated, right? So the ligand is dopamine, it's serotonin, it's whatever. That's it. NMDA receptors are ligand-gated. It is true. But they're also voltage-gated. Anybody see this great guy magnesium sitting right there in the middle of your NMDA receptor and that ion channel? You have to dislodge that magnesium at some point, right? We're going to have glutamate, for example, that's going to bind, it's going to open that channel, but if magnesium is sitting there, it's not going to help us any. The calcium's not going to come in. To get rid of the magnesium, we have to change this internal potential, right? The potential, the membrane potential. We have to get that high enough to dislodge that magnesium. So it's sort of a two-step process. And we'll talk a lot about NMDA receptors and this voltage-gated and ligand-gated business when we talk about learning and memory, whatever chapter that is. So get excited about that one. None of the rest.
Kidneys.
Huh?
Except my kidneys.
Your kidneys, yeah, right? I mean, wow. Here's the GABA receptor. Yeah, they do all look like bell peppers, by the way. It's a true story. Everybody loves bell peppers, right? Anybody hate bell peppers? Really? Yeah, that's okay. I'm not like a huge fan of bell peppers. So here you go. Here's your GABA site. You've got some other sites for like benzodiazepines, alcohol, so forth. Not a big deal. All right, let's talk a little bit about acetylcholine. This is a pretty major neurotransmitter. Comes out of a part of the brain we call the pons. It's going to play a role in sleep, out of your forebrain for learning, and then the medial septum for memory. Don't worry too much about this right now. We'll hit acetylcholine later. I just want to introduce a few of these to you. This is kind of cool. These are drugs that seem to act on glutamate and GABA systems. So it'll tell you the drug over here, and then it'll tell you like how it works, whether it's an agonist, antagonist, whatever. Here's an interesting one. How many of you have heard of PCP? right? So I saw a few hands go up. It's actually an indirect NMDA receptor antagonist, which, not surprisingly, means it's going to impair learning. Okay? I don't know if that was a shock to anybody. Okay? So you can give rats PCP, for example, and they probably won't learn how to get through a maze, right? It's not so bad. All right, this is a rat brain. In case you've never seen one of those, the drawing, it's half of a rat brain. Cut down the middle. Don't ask what we did with the other half. But this half we drew a picture of. Okay, and we're going to show you this. What I want you to see from these next few slides is we're going to see neurotransmitters and their sort of projection systems, right? Where do they start? Where do they end? And I want you to think about some interesting things. Okay? So this is the acetylcholine pathway in the brain. It's made out here in the locus ceruleus. That means the blue area. Seriously, that's what we mean there. If you cut the brain open and you take a look without any sort of chemical processing, it sort of looks like a blue spot. That's why we call it the blue space. There's also some acetylcholine, as we talked about, coming out of the basal forebrain. It's going to go up to cortex for that sort of learning process. And we have some coming out here. Look at this guy. That's the amygdala. That's an important brain region for like fear responses. So you can imagine learning and memory is going to be involved in that process, but also the amygdala is going to need to tap into learning and memory processes later to make sure that, hey, that's something I should be afraid of or not. Here's the synthesis pathway of acetylcholine. You don't really need to know this process, but I think it's a really great illustration of the general approach of how an enzyme creates and then how an enzyme breaks down a particular neurotransmitter. So here we have something called acetyl-CoA. Find my mouse. We have acetyl-CoA and choline. We have this guy called choline acetyltransferase. This is really complicated. We take the choline and we pull off of that this little guy, and what we're left with is coenzyme A and then acetylcholine. To break that down, we use something called acetylcholine esterase, which just takes acetylcholine and breaks it back down into the acetate ion and choline. So it's sort of this is the degradation process or the destruction of acetylcholine, and in this process is the synthesis pathway. Think about where we could put in an agonist or an antagonist in this process, right? If we were to block acetylcholine, or choline acetyltransferase, if we blocked that, then that's an antagonist, right? Because we're no longer producing acetylcholine. If we blocked this enzyme, acetylcholine esterase, that's actually an agonist, right? Because we're blocking the breakdown and we're going to be left with more acetylcholine. Here are some drugs that act on the acetylcholine system. This is interesting. There's that botulinum toxin. Prevents the release of acetylcholine in the peripheral nervous system. So you're not going to be able to move. So that's something. How many of you love black widow spiders? Nobody. Nobody's like, yeah, I'm just going to snuggle up to one of those guys. They also have venom that will actually stimulate the release of acetylcholine. At first you think, well, that sounds exciting. Except you're going to just like have a bunch of spasms, right? Until you run out of acetylcholine and die. So watch out for that. Sounds like fun, right? Jason's back there like, I got a whole horde of black widow spiders. You guys just watch out. I don't know. You don't have a horde of black widow spiders. No, that's fine. Hey, how many of you have ever had surgery? You don't have to answer that. A lot of people have. Well, you did. It's like, oh yeah. Oh, I didn't have to answer that. Sorry. So atropine is a quite often a medication they'll give you, a drug they'll give you when you're headed in for surgeries. It does some cool things. Yeah, it blocks pupil constriction, but also blocks saliva production. So what's a great thing to do while you're under anesthesia? Not choke on your own saliva. That's an awesome thing to try to do, and atropine will help you with that. So there you go. Here's curare. That's That's a poison, again, that's going to prevent muscle contraction. Acetylcholine obviously has a lot of stuff on muscles. Matt, you had something?
Yeah, so I was just curious, so for the black widow spider, if you get bit and you have that, do they give you the curare in some form?
Sure.
We do know what I mean, though, like.
Yeah, no, yeah. No, so absolutely. So what they would have to give you is something to reverse, right, the release of acetylcholine. So the antidote is just going to be something that's going to block the release of acetylcholine.
I don't know if it was like how they introduced like the antitoxins, just like the toxin, but not as strong or something like that. I don't know.
Yeah, they could give you botulinum. I mean, that's what you should do. You should have a vial of Botox every time you go out in the woods, just in case you're bitten by a black widow and you just. Nope. I'm gonna write that in a survival manual. It'll be an exciting read. All about kidneys. Slap yourself in the kidneys before you go out. Nobody's gonna do that. Speaking of antidotes, did you read that weird story? I don't know, this is like a news story, because I read the news. You know, Kim Jong-un's half-brother who was killed with the VX nerve agent that got rubbed on his face at the airport? Nobody followed that story. That was no, seriously, true story. Weird one. 5 days before that, he met with an American spy who probably gave him an antidote to the VX nerve agent that he had in his backpack. He didn't get it out in time to save his life. Here's the story. If you think you're going to be killed by someone and it's going to be through a poison, put the antidote in your hand. So you just have it ready. I thought it was a weird story though, right? Like he had the antidote for the nerve agent that was used to kill him.
So it was on his face?
Yeah, they rubbed it on his face.
Like how did that go?
I don't really know how VX works. They just kind of like ran up to him and like splashed it and rubbed it on his face. Like two women did in an airport. So, you guys don't remember that story? Where have you guys been? That was a big story. I know there have been like other big stories, right? And if you've been watching the news, there's like a lot of big stories going on, right? I mean, geez, like the Grammy snubs, right? I mean, that was a big one. I'm sure you guys were all worked up about that. You don't watch the news? No, that's okay. You should read it at least. That's what I do. I read it. I can read it faster than they can tell it to me, I think. Except that at the rec, right, Eric? So what I would like at the rec are headphones that pick up all of the audio, so I can just like switch between the data streams and have like multiple things going on at the same time, so I can actually like hear 2 or 3 televisions at once. Otherwise, I'm trying to like read the closed captioning, and that's hard to do. And it's sometimes incorrect, which is problematic. Hey, who wants to learn about dopamine? Dopamine's in this group called monoamines. It's not just dopamine. Dopamine's kind of the main guy. Dopamine is a catecholamine, as is norepinephrine and epinephrine, so it's kind of like a subgroup of monoamines. We already talked about L-dopa being a precursor to dopamine. It's actually a precursor to all of the catecholamines. Once you get dopamine, you can do a couple extra steps and end up with epinephrine or norepinephrine, or you can just stop right there and go like, hey, dopamine's awesome, right? Not a big deal. We'll talk more about Parkinson's disease later and the treatment of Parkinson's disease with L-dopa. Those are your catecholamines. Let's see. There are sort of 3 pathways for dopamine. We'll talk about these as we need to. A couple of these are involved in sort of learning, memory, and reward systems, like things that make you feel good. The nigrostriatal pathway is involved in the movement disorder Parkinson's disease. There's the substantia nigra projects to the striatum. The dopaminergic neurons in that pathway degenerate, and then that's what causes difficulty with the movements for folks with Parkinson's disease. Here you go, your dopaminergic pathways, again, substantia nigra. That's actually going to be the one going to the caudate and putamen, which is the striatum, right? That's going to be the one for the movements. The ventral tegmental area, on the other hand, this guy is important for a lot of things. We're going to talk about maternal behavior and drug addiction in particular, and that's going to project to an area called the nucleus accumbens. That's going to be a major circuit for drug addiction and reward pathways, and so that's going to be something important for us to think about at a later time. Who's excited to learn about maternal behavior? Yeah, get your kidneys worked up for that. Don't worry about this. It's not too big of a deal. Oh, here's monoamine oxidase inhibitor. We already talked about that. Here's a little diagram for you, just for your viewing pleasure. Norepinephrine. We should talk about norepinephrine coming out of the locus coeruleus. We already talked about that. It's in that sympathetic division. Again, the sympathetic division is the division that gets you amped up, right? Parasympathetic is going to bring you back down. Okay, so it's in that sympathetic division. Not a big deal. Here you go. There's the locus coeruleus. It's going to go down the spinal cord, head out to the cerebellum, cortex, all kinds of places, including your amygdala and your hypothalamus. We'll talk a lot of hypothalamus later. It's going to be exciting. All kinds of hormone things going on. It's going to be fun times. Serotonin. We should spend a little time here. It is still a monoamine, but it's in the category of indolamines. Don't worry about that. It's just related to the chemical structure, right? They're just classified differently. They're in a different synthesis pathway, serotonin is, than the catecholamines, which were the dopamine and the norepinephrine and epinephrine, right? Again, it plays a role in the regulation of mood, control of eating, sleep, arousal, regulation of pain, all kinds of things. This is why we give folks drugs that affect their serotonin levels for things like depression, things like irritability, aggressiveness, anything you want to kind of stabilize someone's mood. An SSRI is sort of a good first pass at that. Ray, you got a question?
Oh no, I was just working out my head, sorry.
That's
so
okay.
It's derived from tryptophan, and tryptophan has an endo group on it, that's the functional group. And I saw it was an endolamine, and I guess it has that functional group, that's why it's, okay, that
Yeah,
makes sense.
you're right there, Ray.
Okay.
Way to go. Nobody else needs to be there, but you are, and that's great. Okay. No, the rest of you, I'm not going to ask you about chemical structures. I'm not, but if you understand the chemical structure, it makes a lot more sense, right? So Ray's understanding, he's like at another level of enlightenment from the rest of you right now. So strive to be there. You're good. There are drugs. Hey, who's heard of Prozac? I mean, that's like pretty standard, right? I'm assuming everybody has. That's an SSRI, right? So there you go. Here are your serotonergic pathways. Kind of start down here in the dorsal raphe nuclei. Some of the substantia nigra. They're going to be projecting all over the place. Still the amygdala, still the hypothalamus, up to cortex as well. We talked a little bit about histamine. We're not going to talk a lot about histamine. We will talk about it when we get to that sleep and wakefulness chapter, which is going to be exciting. Not going as many places. That's okay. Here are some drugs that work on your monoamine systems. Some of these you've heard of, some of them you haven't. That should be an L, not an I. So, cocaine, for example, it's going to block dopamine reuptake, right? So where dopamine's going to be available at your synapse, so that's something. There are specific receptors of dopamine. Apomorphine, for example, is a particular D2 antagonist. Doesn't really have much use except in research. Here are some other ones. Serotonin. Let me try to find another fun one here. Fluoxetine, fenfluramine. These are both. They block reuptake. Fenfluramine's not really prescribed anymore. There's some nasty side effects to that for long-term use, so very safer drugs. And so, if given the option, always take the safer drug. If somebody says, here's the red pill and the blue pill, they'll both make you feel better. The red pill will likely kill you. The blue pill won't. Take the blue one. Just a word to the wise. We should talk about peptides. What's a peptide? This is when you get really excited, so you get peppy, and it's at the beach, so you have a tide. No. Peptides are when you have 2 or more amino acids, but not quite enough to make a not enough to make a full protein, right? So we'll call that a peptide. Your endogenous opioids, for example, are peptides, right? They're small sequences of amino acids, which can also function, as we've already said, as neurotransmitters, neuromodulators. Lipids, of the lipid-based neurotransmitter, neuromodulator stuff, the endocannabinoids. are the kind of the guy there to think about, okay? Here are drugs that work on those peptides and the lipids, right? So you have opiates. That's just sort of in general, opioids and what they do. Naloxone, for example, that's an opioid antagonist. You guys have probably heard of naloxone and some of the other variants of this. It's used to reverse opioid overdose. All right. Matt, go ahead.
Sorry, I was curious, like, why is there no data on?
That's, I think they just kind of put that on there because,
I don't know if that was you or the slide or whatever.
it's the slide, it's just sort of a blank, right? So like lipids, and then these are the drugs that affect lipids, like lipid things. So like if you go back and you look at the other charts, they have a similar thing where it's like histamine, there's not any data about histamine. Histamine is the neurotransmitter, so we're thinking about what's the effect of histamine on histamine.
All right.
You see what I'm saying? It should be null. It should be empty. All right. Any questions about that, folks? It's a good question, actually. All right.